Hello friends, welcome to Ocular Surface Gurukul. Welcome to the next surgical masterclass, this time on reconstructing the fornix. Well, before we go ahead and reconstruct the fornix, let us first understand what are its functions. Well, a good functional, well-formed fornix facilitates ocular motility, even tear film distribution, and thus helps to maintain a healthy ocular surface. The surgical approach for reconstructing the fornix will most importantly depend upon the underlying cause, whether we are dealing with a condition which is immune mediated or non immune mediated. Immune mediated conditions like Steven Johnson syndrome or OCP will require the patients to have an adequate control of the underlying disease by being on oral immunosuppressive therapy, which is actually not required when it is a non immune mediated condition like a chemical injury. The phonics shortening, whether is it progressive or is it stable, and what is the aim of our intervention? Is it a visual rehab that we are planning for, or is it only cosmesis that the patient is looking for? The counseling will significantly vary depending upon the aim for this intervention. Was there any previous intervention that was done for the phonics shortening that we are seeing now? And how inflamed is the eye? Whether the patient's surface inflammation needs to be controlled before planning the intervention. The factors which need to be considered when we are taking up the patient for a visual rehabilitation, in addition to symblepharon grading, would be the status of the eyelid, whether there is an associated entropion or ectropion, which also needs to be taken care of, how moist or dry is the eye, and the extent of LSCD, whether we are dealing with a partial or a total, because that will need to be addressed once the fornix is formed. How thin or scarred is the cornea? What is the extent of scleral thinning if it is present? Whether that will require an intervention when we are reconstructing the fornix? What is the status of glaucoma? Whether the patient needs a diode cyclophotocoagulation or some other intervention to get the IOP under control? And what is the visual status? Are we sure that we have ruled out amblyopia? Next, however, if we are dealing with a cosmetic intervention, in addition to knowing the grading of symblepharon, knowing the status of the eyelid for the same purpose as we discussed is important. Corneal status here again becomes extremely important to know whether there is any underlying ectasia or staphyloma, because inserting and placing a cosmetic contact lens or even the cosmetic shell might be an issue. Knowing the tear levels, how moist or dry is the eye, will further help in understanding how comfortable the patient would be using a cosmetic contact lens. Now, the causes of symblepharon, as we discussed earlier, is extremely important. In immune mediated conditions like SJS and OCP, we would require the patient to be on adequate oral immunosuppressive therapy before we touch these eyes, which is not the case when we are dealing with non immune mediated conditions like ocular burns or trachoma or an adenoviral conjunctivitis. Kherka and al. Had proposed the surgical strategies for fornix reconstruction based upon the symblepharon severity, and this is what really marks the basis of most of the management strategies proposed for symblepharon release. They have defined the symblepharon based on the length, the width, and the inflammation. Length is the shortest distance through the symblepharon from the lid margin to the limbus. Width is the longest horizontal or circumferential width in reference to the length of the eyelid, and inflammation is depicted by the hyperemia of the conjunctiva. Now, why is this grading so important? Well, it is the length which determines the type of surgical procedure, the width which tells you the extent of surgery and the graft required, and inflammation will decide or help us determine the duration of the intraoperative mitomycin C application, or whether you have to give in additionally tricot injections to these patients. So let us see what is it that Kherkan et al. Really proposed. Well, if we are dealing with a grade 1 symblepharon where the residual recessed conjunctiva is sufficient to cover the palpebral surface, what we would require is only an amniotic membrane transplant after the psychiatric lysis to cover the bare area. However, if it is a grade 2 symblepharon where the recessed conjunctiva is sufficient to cover only the tarsal surface and not the palpebral and the bulbar. In addition to the amniotic membrane transplant, you might require a conjunctival autograft along with an anchoring suture to keep your tarsal surface away from your bulbar surface so that the fornix remains formed. In cases of grade 3 or 4 symblepharon, when the recessed residual conjunctiva is not sufficient to even cover the tarsal surface, here, in addition to your amniotic membrane transplant on the bulbar surface, you would require an oral mucosal transplant on the lid margin to take care of your tarsal and the palpebral defect, along with an anchoring suture or a fornix forming suture to keep the palpebral and the tarsal surface away from each other. Let us go through a few case scenarios to understand this a little better. This is the first case, a 19-year-old female who had a grade 1 symblepharon following a chemical injury 10 years back. Her primary concern was cosmesis because a symblepharon was causing a ptosis. We went ahead with a symblepharon release and amniotic membrane transplant. At glass appointment, you can see that the surface is well epithelialized, the fornix is being taken care of, and the patient was quite happy. Second patient, a case of a unilateral chemical injury again, a 25-year-old male with a grade 2 symblepharon and a total limbal stem cell deficiency, keen for visual rehabilitation. We went ahead, released the symblepharon, placed an amniotic membrane transplant along with a conjunctival autograft on the superior bulbar surface. At glass appointment, the surface had epithelialized and the fornix is well formed. Few months later, we took up the patient for an auto simple limbal epithelial transplant, and you can see a well formed fornix with a clear cornea 3 months following the transplant. Next is the case of an 11-year-old male following a unilateral chemical injury had a grade 2 to 3 symblepharon with a partial LSED. You can see the superior limbus appears to be completely intact. Well, the patient was keen for a visual rehabilitation as this symblepharon was causing a significant astigmatism. We went ahead with a symblepharon release and an amniotic membrane transplant on the bulbar surface and a conjunctival autograft with fornix forming sutures, just like we do it in a pterygium surgery. At glass appointment, you can see a well formed fornix, a surface which is epithelialized, and the patient was happy as the astigmatism had significantly reduced. Another patient, a case of an unilateral chemical injury, a grade 3 symblepharon with a partial LSED. Again, if you see, the superior limbus appears intact. The patient was keen for a visual rehab. The symblepharon was occluding the visual axis. Well, we went ahead with the symblepharon release with the mucous membrane grafting, as after release, not even the tarsal surface was getting appropriately covered by the conjunctiva, and we did a mucous membrane graft to the lid margin along with an amniotic membrane transplant to the bulbar surface and fornix forming suture. The surface had well epithelialized at last appointment, which is 6 weeks, and the patient was happy. Now, a case of a 10-year-old female child following a unilateral chemical injury had a grade 4 symblepharon with a total limbal stem cell deficiency and was keen for a visual rehab. We went ahead with the Fornix reconstruction, released the symblepharon, placed the mucous membrane graft on both of the upper lid and the lower lid, and an amniotic membrane transplant on the entire bulbar surface, along with Fornix forming sutures. At glass appointment, the fornices were definitely better formed. However, there was still some amount of shortening present. So patient was taken up for a superior symblepharon release. This time we also placed a conjunctival autograft on the bulbar surface. 3 months down the lane, when the fornix was well formed, we took up the patient for an autosimple limbal epithelial transplant to aid in the visual rehabilitation. So, a child who presented with a grade 4 symblepharon and a total LSCD following fornix reconstruction had a good well formed fornix and a relatively clear cornea following the auto slit. Moving on to the immune mediated disorders like OCP or SGS, let us see how this spectrum is different from what we just saw of chemical injuries. Well, here, the factors that need to be considered while planning the surgery would be first is the aim. Why are we reconstructing the fornix? Is it because the patient needs a cataract surgery, or do we need to insert the scleral lens, that is the PROS lens, to aid in visual rehabilitation? Or is there an exposure? The simulafron is causing an exposure which is resulting in keratinization or dryness, or is there a mechanical abrasion which is caused by the simulafron? What are the tear levels? How moist is the eye? Do we need to do a punctal cautery or a tarsorrhaphy to make the surface a little more moist? How inflamed is the surface? And the need for oral immunosuppressive therapy. A surgical intervention in patients with underlying immune disorder cannot be done in an eye which is inflamed and has to be done under an adequate oral immunosuppressive therapy. Let us go through a couple of cases. This was a known case of OCP, a 65-year-old female who was awaiting cataract surgery but was not on any kind of oral immunosuppressive therapy when she presented. She had a grade 2 simulafron, an active inflammation, Schirmer's of around 8, and a total cataract. Now, before planning or touching for a Fornix reconstruction, we initiated her on an oral immunosuppressive therapy with mycophenolate mofetil. 3 months following which, once her surface inflammation quietened, the eye became quiet, we took up the patient for a simulafron release along with an amniotic membrane transplant, and during this surgical period, we put her on perioperative oral steroids in addition to continuing with the mycophenolate mofetil. 2 months later, this was followed by a cataract surgery, again under oral immunosuppressive therapy. The next is a case of a Stevens-Johnson syndrome in a 25-year-old female who presented to us with a dry keratinized surface. However, there was a good view of the anterior chamber. Her best corrected visual acuity was only finger counting, which improved to 624 with a PROS trial. However, they were not able to fit the PROS well because of the simulafron bands, and so we decided to go ahead to release the simulafron. We did a simulafron release with an amniotic membrane transplant and a tarsorrhaphy because the eye was significantly dry. 2 months later, once the surface had epithelized, the patient was fitted with a PROS lens and with the vision improving to 624. To summarize, a thorough pre-op evaluation becomes mandatory for any patient being considered for Fornix reconstruction. Tear status is one of the most important prognostic factors. Each of them will require a tailored approach and coordination with the immunologist, especially if we are dealing with an immune mediated disorder. Follow the rule, surface stabilization, and then visual rehabilitation, and this will definitely result in a favorable outcome. Thank you. We do offer short term ocular surface fellowship for 3 months. Do email us if you're interested. Thank you for watching.